neurologist affiliated to Department of Neurology, Erlangga Hospital, University, Surabaya, Indonesia. She's from Indonesia. Okay. And her areas of specialization are sleep disorders and clinical neuropsychology. She's heading the department and she has 19 publications to her credit. I would like Dr. Fidiana to start.
Hello, everyone. Namaste. Can you hear me? Thank you. My name is Fidiana from Indonesia. I work in the neurology department of Erlangga University Hospital in Surabaya, Indonesia. Before I begin, I would like to thank the committee and the Professor Rafi Gupta for inviting me today. So today I will present a case about a child who wakes up feeling terrified from sleep. So for the case, is a 2 years old female child, which often wake up in the first hours of sleep with crying, screaming, and kicking for about 30 minutes. While the child was having the episodes, the eyes were closed. She did not respond to any sound and could not be calmed down with cradle or any toy. Even if the patient opened her eyes, she cannot be calmed down by anything that her parents did. So this episode occurred approximately 3 to 5 times a week, and it was accompanied by screaming or crying and sweating or labor breathing. The patient did not have any other symptoms nor seizure at daytime, and the parents informed that if the patient had tantrum at the daytime, then she most likely to have an episode at nighttime. So because this is a child case, we obtained the delivery history as follows. The patient was delivered by C-section with normal Apgar score, and there was no developmental delay. Physical exam shows no abnormalities, no neurological deficit. Patient's father had history of somnambulism or sleepwalking when he was about 5 or 8 years old. The patient's older sister also had similar episodes when she was 2 years old, so approximately the same age as this patient. But the difference is the episode that this patient older sister had is shorter, so it lasts for 5 up to 10 minutes. So if you talk about a parasomnia, I would like to talk a little about the basic knowledge about parasomnia. So as defined by ICSD-3, the parasomnia is undesirable physical events, which includes movements, behaviors, or experience, whether it's emotions, perception, or dreams that occur during, within, or during arousal from sleep. So from the classification of the sleep disorders, we have that 7 sleep disorders, which one of them is parasomnias, and parasomnias is can also be divided into non-REM parasomnias, REM parasomnias, other parasomnias, and isolated symptom or normal variant. We're going to talk about today about non-REM parasomnias, which includes the disorder of arousals. So the disorder of arousals consists of confusional arousals, sleepwalking, and sleep terrors. And there's also related eating disorders. So basically, in parasomnia, there's a concept where the awake stadium, non-REM and REM stadium can occur simultaneously or oscillating rapidly. The overlapping stadium between the wake stadium and REM results in REM parasomnias, while the overlapping state of wake stadium and non-REM sleep results in non-REM parasomnia, including the disorders of arousals. There's also differential diagnosis that resembles the clinical symptoms of parasomnia, which are such as the uh, seizures, nocturnal frontal lobe epilepsy, and also psychogenic spells such as the dissociative disorders or post-traumatic stress disorders. So this from the study that uh, conduct the SPEC imaging on also EEG in patients with parasomnias. In the SPEC imaging, there was a decreased blood flow in the frontoparietal associative cortexes, while the EEG in this area shows the anterior theta activity and sometimes vertex waves or spindles, which consistent with non-REM sleep. There's also found increase of blood flow in the posterior cingulate cortex and in the anterior cerebellum. And the EEG in this area shows a posterior dominant alpha rhythm, which can be found in wakefulness. So the following is an illustration of the condition of the brain when non-REM parasomnia occurs. The blue areas are areas that have a decreased blood flow during the episode, which include the frontal associative cortex, parietal associative cortex, and the red areas shows increase in blood flow during this episode. So the areas of the brain that experience increased blood flow is the temporopolar cortex, the frontal associative cortex, sorry, uh, the area that have a decrease of blood flow is frontal associative cortex, parietal associative cortex, and also the hippocampus. That's why patients with parasomnia often have amnesia because the hippocampus has a decrease of blood flow. So the activity is also decreased in the episode of parasomnias. While the motor cortex, the temporopolar cortex, the anterior cerebellum have increased blood flow, so it resembles the activity in the wake stage. So these are the comparison of the EEG between the area such as the motor cortex, frontoparietal association cortex, the limbic cortex and amygdala, and also hippocampus. As we can see here, that the motor cortex during the episode is similar to the wave of wakefulness. So it's consistent with the higher motor activity in patient with non-REM parasomnias. While the frontal parietal association cortex and the hippocampus have a decreased blood flow, and the EEG shows that the waveform is similar with the sleep waveform. So these are the three factors that also play a role in influencing the occurrence of non-REM parasomnias. We have the predisposing factors such as the genetic role from uh, probably the family or first degree relative. Priming factors is also the main factors that contribute in parasomnia, such as slow wave sleep arousals, the use of medications, alcohol, sleep deprivation, fever, and stress. And there's also precipitating factor such as a comorbid of other sleep disorders like sleep disorder breathing or sleep apnea, periodic limb movement, and also there's a external stimuli like a external noise from the environment that could also precipitate the episodes. So these are the clinical characteristic of the non-REM parasomnia. So we can see that the similarities between this non-REM parasomnia is the occurrence. So it occurs in the first third or half sleep period, and also the sleep stage. It happens in the slow wave sleep or N3 stage. For duration, approximately the same year between 1 to 15 minutes for conventional arousal. Somnambulism can last up to 30 minutes, while sleep terrors usually have a shorter periods. For the autonomic activation, sleep terrors have a moderate to extreme autonomic activation. So the patient usually shows sweating or labor breathing or tachycardia. And the other similarities are all if these non-REM parasomnia, they have a variable amnesia for the event because of the decreased blood flow in the hippocampus area. So it's uncommon to fully awake patients with non-REM parasomnia. They tend to be difficult to awake from the sleep, and even after they wake, they usually didn't remember about the episode. For the main differentiation between the conventional arousal, somnambulism, and sleep terrors, that conventional arousal is a patient only sit up in bed feeling confused but did not respond to any other stimuli. For somnambulism, it's more complex movement and involve ambulations. For sleep terrors or night terrors, there's a prominent autonomic activity with agitated motor activity, also often accompanied by screaming or crying. Okay, beside other disorder of arousals, we have to differentiate uh, the case of disorder of arousal from nocturnal seizure. Uh, it can be differentiated from the age of onset, which disorder of arousals tend to start in childhood and tend to diminish with increasing age, while nocturnal seizure can happen in any age. Family history are more likely happen in disorder of arousals compared to nocturnal seizure. For the frequency, for the disorder of arousal is probably up to 2 episodes per night, but nocturnal seizure can be higher in frequency. Uh, for the stereotypy, disorder of arousals have low stereotypy, while nocturnal seizure often uh, have a very high stereotype. For the time of sleep period, nocturnal seizure can happen at any time, while disorder of arousal usually within the first third or within the first half of the night. Beside differentiating from nocturnal seizure or other disorder of arousals, we have to distinguish the non-REM parasomnia or night terrors in this case with REM sleep behavior disorders. So for the characters of the time, the non-REM tend to happen in the first third up to half first of the night, while REM sleep behaviors disorders often occurred in last half of the night because in the first third of the night, the entry, especially in children, is more prominent. So there's more non-REM or a longer period of non-REM episode, especially in slow wave sleep. While in the last half of the night, it tends to have a more uh, longer time for the REM stage. So the REM sleep behavior disorder is more likely to happen in the last half of the night. For the behaviors, non-REM parasomnia include simple to complex behaviors such as in sleepwalking or sleep-related eating disorders. But REM sleep behavior disorder is typically very agitated, like kicking or punching the bed partners, and often have a loud vocalization or screaming or swearing. For the eye position, during the episode, non-REM parasomnias patient tend to have an open eyes, while REM sleep behavior disorder patient have closed eyes. And a patient with non-REM parasomnia often seems confused or disoriented compared to the REM sleep behavior disorder. So it's is easier to wake a patients with RBD than patients with non-REM parasomnias. And if RBD patients is awakened, then the patient will fully oriented. Compared to the non-REM parasomnia, it's very difficult to awake a patient with non-REM parasomnias. And even if the patient managed to awake, uh, usually they will feel confused and disoriented. And also, they tend to not remember the episode they were having compared to the RBD, because it's often related to the dream presentation in RBD. So as we see that the arousal threshold is high, that's why the patient is very difficult to be awakened in patients with non-REM parasomnia, while RBD patients have a low arousal threshold, so it's easier to awaken. For the triggers, for non-REM parasomnia, we have the sleep deprivation, noise, touch, possibly another sleep disorder such as OSA, PLMD, or it could be triggers by the hypnotic medication or alcohol use in adult. For the RBD, the triggers usually the use of alcohol and antidepressant. For the PSG findings and non-REM parasomnia, there were frequent arousals in the entry stage of slow wave sleeps, while the REM behavior disorders tend to show the increased EMG activity during REM sleep. So the amplitude of the EMG wave is higher in REM sleep behavior disorders. So, non-REM parasomnia is common in children and is also linked to developmental immaturity of inhibitory neural projections, synapses, and receptors. Gradually and spontaneously resolve in adolescence without intervention. So, the case I was talking about earlier, about the 2 years old female patients, the clinical symptoms resolve within approximately 8 months after it started, and it tends to diminish alongside with the decreased incidence of tantrum in the daytime. So this is shows that the reduction of stress in daytime could also affect the incidence of the episodes of non-REM parasomnia at nighttime. Non-parasomnia is also can persist or start in adulthood, or it can persist from childhood up to adulthood. So there's also family history of non-REM parasomnias, uh, which is more common in patients with childhood onset. So from the case I was talking about earlier, that the children have an older sister that also have a non-REM parasomnia, and a father that's also had a sleepwalking episode when he was a child. So there's a couple screening questionnaires that could help us in determining or diagnosing patients with parasomnias and differentiate it with other diagnoses such as epilepsy or another sleep disorders. So we have this frontal lobe epilepsy and parasomnia, which tend to distinguish between the epilepsy and parasomnia with the sensitivity is the most high, is up to 100%. Unique parasomnia screening, Paris arousal disorder severity scales, arousal disorder questionnaires. So these four questionnaires, the frontal lobe epilepsy and parasomnia has the most sensitivity, and the arousal disorder questionnaires has the most specificity of 96%. So this is the flap scale or frontal lobe epilepsy and parasomnia. So this scale is useful to distinguish between the epileptic seizure and parasomnias. The questions include the age of onset, durations of the episode, cluster, number, timing, symptoms, aura, a question for determining parasomnia, like does the patient ever wander outside the bedroom during the events? Uh, this is for sleepwalking. Uh, and also stereotypy. So as we know that epilepsy patient tends to have a higher stereotypy than non-REM parasomnia patients. Recall, as we know that parasomnia, non-REM parasomnia patient uh, tends to have an amnestic event, but patient with epilepsy also have amnestic event. But the REM parasomnia patient often can recall the events clearly. Vocalization. So, score minimum 3 indicated that the patient is very likely to have epilepsy, and score less than 0 or less means that the patient is unlikely to have epilepsy. So, it is considered the patient having parasomnia. So this is the Munich parasomnia screening questionnaires, which consists of I think 22 questions, if I'm not mistaken, which besides detecting parasomnias, also can be used to detect other sleep disorders, because it includes such question like the presence of auditory or visual illusions, nighttime cramps, teeth grindings, as can be found in bruxisms, and also periodic limb movement and also sleep apnea. This is the Paris arousal disorders severity scale in English version. So the PADS is beside diagnostic in function, and also to evaluate whether the parasomnia is worsen or getting better.
Dr. Fidiana, kindly conclude
Yeah.
in next 5 minutes. Kindly
Sorry.
conclude in next 5 minutes.
Okay. Okay. Thank you. Um, So this is the arousal disorder questionnaire, which is very specific for non-REM parasomnias, because it can differentiate between confused arousal, sleep terrors, and also sleepwalking. Sorry, I cut uh the last part of the questionnaire because it's very small in the font. So I focusing on the sleep terrors question. So it consists of like 7 questions to determine whether the patient is having sleep terrors or not. Okay, so for diagnosis, video polysomnography is not routinely indicated in patient with suspect of parasomnias. Uh, so PSG is only indicated if there's a um, to rule out a differential diagnosis like coexist sleep disorders such as RBD, nocturnal epilepsy, or OSA. This is the criteria of DOA, or the disorder of arousal. So there's a recurrent or incomplete awakening from sleep, inappropriate or absent responsiveness to efforts of others. There's no associated cognition or dream imagery, partial or complete amnesia. Well, the diagnostic criteria of sleep terrors, the disorders meet the general criteria for disorder of arousals, and characterized by episodes of abrupt terror, typically beginning with alarming vocalization or maybe screaming, intense fear, and sign of autonomic arousals. So what are the managements of non-REM parasomnia? So we have the safety measures, sleep hygiene, pharmacologic, and non-pharmacologic therapy. So what are the safety measures? The safety measures for patients with parasomnia is to provide safety for this patient, like blocking stairways, so patient with sleepwalking will not fall. Uh, Place the mattress directly on the floor. This is to prevent injury if the patient of the child or the child falls out of bed. Preferably sleep alone, especially patient with RBD, because they tend to hurt the bed partners. Use motion detectors. It could be used to detect whether there's a motion. Lock doors and windows. Covering windows and turn off screens. So, keeping the sleep area dark is preferable. Avoid alcohol, caffeines, and remove sharp objects from the sleeping areas. Sleep hygiene, I think you already know about sleep hygiene. Establishing a nighttime routine, get up and go to sleep at the same time, create a healthy sleep environment, turn off electronics an hour before bed, avoid large meals, reducing stress by meditation, performing exercise, and limiting caffeine or alcohol consumptions. So basically, the pharmacologic therapy of non-REM parasomnia, we can use triazolam, zolpidem, lorazepam, or clonazepam, but only in adults. In children, we tend to not intervene with the childhood symptoms of non-REM parasomnia because it tends to resolve without interventions. So what are the non-pharmacological therapy? We have to eliminate the priming factor and the precipitating factor. So like in this case, then the precipitating factor, uh, the priming factor could be the stress showed by the child having tantrums, uh, and also try to try to not intervene while the child having episodes at night, because the more we intervene or the more we try to calm down, then usually they tend to get worse and not resolve. So what are the prognosis of night terrors? The prognosis for night terrors is usually good with child onset because they often outgrowing these episodes by the age of 10 years. And in contrast, excessive movements may become a disturbance that alters family or child's quality of life during an exacerbation. In adult, the prognosis of night terrors, I think, is not as good as child onset because they often accompanied by psychiatric disorders. So for the summary, parasomnia is a disorder of arousals in entry sleep accompanied by motor activity in various forms due to predisposing, priming, and precipitating factors. Non-parasomnia in adults need to be diagnosed and treated accordingly to improve sleep and quality of life of the patients and family, especially bed partners. And non-parasomnia in children usually resolve without any intervention. Thank you.